Today I will be talking on left main bifurcation, and we did discuss few cases here, which were all done by different techniques, and they were all done under IVAS guidance and physiology. We discussed the advantages over one another technique. At the beginning of the 21st century, the left main stenting has become the alternative to centers. At the beginning of the 21st century, the left main stenting has become the alternative to surgery in selected centers. Before doing any procedure, we try to calculate the syntax score. We try to correlate it with 10-year all-cause mortality, whether it favors PCI or it favors CABG. So the syntax score of the patients, syntax 1 and syntax 2 is calculated. Decision making is done. The PCI, suppose the syntax score, this is a hypothetical, syntax score is 21.6. The PCI 4-year mortality is 3.4. Similarly, if the CABG syntax score is 20.7, the CABG 4-year mortality is 3.2%. So we take the heart T considerations. Tertile 2 syntax score was equiposed in our example, and this then the COVID pandemic is going on. The normal cardiac surgical services has not yet been fully resumed, and we try to do more complex cases in this scenario. If we use IVAS in left main, that is very helpful tool to determine the length of the lesion. We can know the length of the lesion. We can know the diameter of the left main. We can know the diameter of the LED, and we can do a stent sizing with this strategy. So the IVAS is when used, we can see the stent deformation. We can see the expansion of the stent. We can see where the stent edge is placed. All these things can be, and in the mid shaft also, we can know how the stent is expanded, or how the apposition of the stent is there. The stent expansion in left main, the MSA of greater than 90% of distal left main reference lumen. And for funnel shaped left main, the MSA of 80% of the distal left main reference lumen can be sufficient for the good result. So the IVAS guiding for left main is important to plan the PCI strategy, whether we use 1 versus 2 stent strategy. Also for the plaque preparation, that is the assessment of the calcification. Then device sizing is important, can be done. We can do the pre-dilatation balloon sizing, stent sizing, and even the port balloon which we use, we can size adequately. Then it can optimize our results when we see that there is adequate stent expansion and full lesion coverage. If there is complete stent apposition on the stent edge, is there any dissection or plaque burden, residual plaque burden, or sometimes the proximal edge of the stents gets deformed? We can find it out by the IVAS and take the corrective measures. So in lesion preparation, we can do the characterization of the plaque. We can see whether it's calcified or non-calcified. Specifically, location and extension of the calcification can be determined, and we can actually select a most adequate device. So in bifurcation technique, in distal left main lesions, the provisional stent strategy is most common approach, If required, another two-stent technique is decided upon the anatomy of the bifurcation and preference of the operator. Preference to provisional stenting is done the from left main to LED, if the circumflex is small, there is no significant LCX disease, and there is a wide angle between LCX and LED. And from left main to LCX stent, if LED ostium is free of disease and LCX is without significant vessel dominant, then it's a preference for a provisional stenting. For a two-stent technique, we give preference if there is a significant and long lesion in the ostium of the circumflex, there is a complex lesion in the ostial circumflex, or there is a narrow angle between the LED and LCX. And there are poor results after provisional stenting. If the stenosis is more than 75%, there is reduced flow or there is dissection. So I come to my case series of patients. Case one, that was a 54-year-old male, post PCI to LED with a sirolimus eluting drug-eluting stent 5 years back. He was hypertensive, diabetic, dyslipidemic. He had a severe LV dysfunction. There was a regional wall abnormalities in the LED territory with an ejection fraction of only 26%. The patient presented with angina at rest since 3 days. Because of the clinical picture, we diagnosed the patient as non-ST elevation MI. Angiographically, just I'm playing the slides. The left of, you can see the left main is diseased with triple vessel disease. LAD proximal is showing restenosis ISR. You can see, if you can identify, there is a clot, grade 2-3 clot was also there in the proximal LAD that might have led to the clinical presentation like a unstable angina. And we went ahead with the syntax score and heart team considerations. We did the IVUS pre-PCI. We could determine the distal reference. We can see the tightest point of the left main. Also, we could see the proximal LAD, which was branching into LCX, showing bifurcation disease there. And we could also assess there was a previous under deployed stent. So we use a co-registration system in our lab where we can move the cursor, and at a point we can see the picture of the IVUS. That is a very beautiful method where we can co-register the angiographic result with the IVUS result. So the BMW wire was crossed, 2.5 into 38 millimeter stent deployed at 14 atmospheres in distal LAD, and a 4 into 23 millimeter stent deployed from left main to LAD at 16 atmosphere. And a pot was done with 5 into 8 millimeter balloon at 18 atmosphere. You could see the plot, the position of the pot balloon is very important when we do pot in the left main. The carina, the distal carina of the which we make, it should be at the distal end of the pot balloon should not go beyond carina, and it should not be very proximal also. That's so that it's a very important point to keep it at a very precise, to place it very precisely and do the pot. Also with IVUS, we saw there was an eyebrow sign which showed us that if we go from left main to LAD, there might be a pinching of the LCX, and the LCX is diseased. So after doing this, after putting the stent in the from left main to LAD, after doing the pot, we did a stenting from left main to LCX through the struts, and a 2.5 millimeter stent was deployed from LCX to OM, and you can see here a final kissing balloon was done, and this was the result post kissing balloon dilatation. Uh, uh, Multiple layers of stent struts were seen when we did an IVUS in the cross-sectional area. So there was a stent deformation at the proximal edge. So we corrected again with a pot, which was done in the left main coronary artery. This time the pot, again, the position of the pot is important. It has to be more proximal than the previous pot, which was done in the left main. And this is the final expansion of the fully expanded left main and fully expanded stent in the LAD. And this was the final angiographic result. This first case we did with the tap technique with the minimal protrusion of the LCX stent into the LAD by a provenal approach. Now I come to the second case, which is a 53-year-old male patient, diabetic of long duration, and the patient again presented with acute coronary syndrome with ongoing chest pain and ECG changes. Otherwise, few days back, patient had stable symptoms of angina on exertion, 3 days and dyspnea on exertion for grade 3, normotensive, obese, had COPD. So very high risks for surgery. You can see angiographically, there was a very huge left main and the patient clinically unstable due to tight lesion in the LAD. If you see the size of the LAD and the size of the left main, there is a drastic difference in the caliber of these two vessels. Also, if you compare with LCX, the left main is still huge. So this was the IVUS pre-PCI, took a distal reference, LAD ostial left main, tight lesion, and this is the angiography. You can see this was a triple vessel disease also. We decided to treat the patient in stages, and first we treated the left main to LAD and LCX bifurcation. So the wire was crossed, the lesion was pre-dilated with 2.5 millimeter balloon at 12 atmosphere. Then we took, we thought of taking a Y technique, or you can call simultaneously SKS technique, where as the patient was clinically sick and the left main was very huge, about the size of 8 millimeter. So we decided to take two stents simultaneously, one into 2.75 into 38 in the left main to LAD. It was simultaneously dilated at 8 atmosphere with 4 into 23 millimeter stent from left main to LCX. And the final kissing balloon was done. So post PCI, good LAD ostium. We had to, we still saw there was malapposition, which was corrected with the pot with the semi-colloid balloon, and this was the final result. You can see very well apposed stents in all the vessels, good flowing LAD, good flowing circumflex, good carina. So I discussed another case. An 80 years old male came to us with angina on exertion, dyspnea on exertion, diabetic, hypertensive, and a known case of dyslipidemia. On angiography, you could see there was left main, tight ostial LCX, also disease in the LAD. And you could, if you could appreciate in these films, there was a lot of calcium in the left main and LAD. We didn't take any chance. We rotated from left main to LCX with 1.5 millimeter burr. Similarly, LAD was crossed and rota from left main to LED was done with 1.5 millimeter wire. So these slides are already discussed. Then the LED lesion was subsequently dilated from distal to proximal part, and it was palpated to see that there is no calcium. With a 3 millimeter balloon, we could see a good expansion in spite of calcium. So we went at with a free mind to stent these vessels. The LCX and LED wired LED, a distal stent 3 into 38 was deployed. It was post dilated at 18 atmosphere with 3.5 into 13 balloon. Then LCX 4 into 38 millimeter. First, after putting the distal LED stent, we put an left main to LCX stent. The LCX 4 into 38 ostial stent post dilated with 4 into 10 at an atmosphere. Finally, a pot was done, and then the lesions crossed from LED to left main to LED, and stented from the LED to left main through the struts. So actually, a Cullot procedure was contemplated. LCX and LT stent were recrossed and dilated. There was a post dilatation in the LED with 3.5 millimeter balloon. Then a kissing balloon with a kissing balloon technique. We did a kiss 3.5 millimeter balloon in LED, 4 millimeter balloon in LCX, and a final pot was done. So this is the stent tools. You can see very good formation of carina, fully expanded stents, and this was the final result. You can see a very nice result with the Cullot technique. So to conclude our cases, the multi-layered provenal strategy, to my mind, still remains the treatment of choice for left main bifurcation lesions. In provenal stenting, second stent can be deployed is and when required. There is a considerable role of intravascular imaging and physiology in optimizing the results and improving outcomes. Cullot's technique is wonderful technique. It can be used as a provenal stent strategy. Double kissing Cullot should be a preferred technique in which we add another step of double kissing before we do the final pot. In patients who present with acute coronary syndrome, the SKS is still a viable technique. It is especially useful if caliber of left main is too large and the branches of LED and LCX are disproportionately small. So, what do we see with IVUS, in patients? That when we do an IVUS for optimizing angioplasty in these patients post PCI, we look for any edge dissection, as you can see in our number 1 IVUS picture. Then you can see, is there at the edge, is there any residual plaque burden? So the plaque burden should be less than 50% where the stent edge falls. Then we look for any malapposition, as you can see in this diagram. In our case also, we corrected the malapposition after seeing it with IVUS. Then you can see there is an incomplete apposition. There can be malapposition, incomplete apposition, or incomplete expansion. All these things have to be cross-checked with imaging, with intravascular ultrasound. The minimal stent area should be more than 1.5 millimeters square with IVUS and 4.5 millimeters square with OCT, and the average reference lumen should be more than 80%. So these are the optimization points when we use IVUS for optimizing our patients, especially left main patients. There's a trial going on in which is the optimal randomized control trial, where the role of the IVUS, how it affects the mortality. It's a randomized controlled multi-center international study, and it studies the indication of PCI of the left main coronary artery, and patient will be followed for 2 years after the index procedure. So to conclude, IVUS imaging for left main disease PCI is definitely helpful. It evaluates the severity of a disease and its extent. It characterizes the left main plaque and its calcification. It guides us for plaque preparation. It guides us for sizing of the stent diameter and length, and it optimizes our results. The IVUS guidance of left main stenting provides a prognostic benefit with respect to use of angiography alone, particularly when using a protocol with predefined optimization criteria. Get advantage from IVUS when dealing with left main disease. Thank you very much.
Thank you, Robert. This was very well done. Any questions from anybody?